Okay.
Hello, hi. Good morning, everyone.
Good morning, sir.
Dr. Hiren, good morning.
Good morning.
Dr. Modi, good morning. Welcome. Good morning, Indu madam.
Good morning.
Should we begin, ma'am, or we wait for a few minutes, sir? Whatever you say.
Sonal and Dr. Hirena both there.
Dr. Hiren, sir, I can see. Sonal ma'am's name I can't
Sonal
see.
must be joining only.
Yeah, we'll just wait for a minute. Let Sonal join and then we can start.
Yes, sir.
Welcome, Gitesh.
Thank you, ma'am.
Yes. From the Rainbow side, Dr. Naveen and all have joined.
I can see one initial. I don't know who that is. So Dr. Sumaya, has Dr. Naveen sir joined? Sumaya? I think she's calling. So.
Okay, we just wait for that and then we can start. Once Sumaya is there, we can start because.
Dr. Sumaya, could we begin? Are you there?
She must be. I think she's ready. So,
Oh, good morning, sir. Good morning, sir.
hi, morning. This is Naveen here. How are you?
Yeah, hi. Welcome, Dr. Naveen.
Hi, hi.
Yeah.
Am I audible?
Yes.
Yes,
Okay.
you're audible.
Okay, so we will begin now. Yeah.
So,
Yeah.
welcome everyone
Hi.
to the fifth session of the Pulmo Radio Crosstalk hosted by IIP NRC, IIP Mumbai and SRCC Children's Hospital. I know I can speak for everyone when I say that the last few sessions have been extremely informative. They have been they've helped in defining further steps of management of the cases that we have understood, that we have discussed. We've understood the pathology, the radiology, and the pulmonology aspects much better. And I can say with conviction that these are definitely very useful and very beneficial from all of our points of view. So I invite Dr. Indu ma'am to say a few words and just begin the session, please. Welcome, Dr. Rawat sir. Welcome, Dr. Naveen sir. Our radiology consultants, Dr. Hiren sir, Dr. Sonal ma'am, and our speaker for today from Rainbow Children's Hospital, Dr. Sumaya.
Thank you everyone for joining in the morning. I think I'll have to push a few more people to get up a little more so that our attendance improves with such a beautiful session that we do. And I thank the Rainbow Children Hospital, especially Dr. Naveen and Sumaya for taking the center stage this time. Of course, without much ado, I wish to start, and I definitely thank my radiology team for throwing light on things that, as clinicians, where it always helps us clinicians to go a step forward. Over to you, Dr. Rawat, and then we can ask Dr. Sumaya to start.
Thank you, Dr. Indu, and warm welcome from IP National Hospital chapter. Good morning to all, Dr. Indu, Dr. Hiren, and your amazing residents, Tanvi, and all people who are on board. And I think you are doing an excellent job of organizing these Pulmo Radio crosstalks. Thank you to SRCC, and thank you to our radiology team for being with us and educating us for these sessions. So without taking much ado, I'll request Sumaya to start the session, please, straight away.
Thank you, sir. My screen is visible.
Yes.
Yes, it is.
Start.
Good morning, everybody. Good morning, every faculties. Today, I am going to present on the topic exploring the nexus between vascular and airway anomalies. Myself, Dr. Sumaya C., Fellow Pediatric Pulmonology, Rainbow Children Hospital, Hyderabad. My mentor is Dr. Naveen Sarathi, Consultant, Department of Pediatric Pulmonology in the same institute. So, coming to the contents of my talk, I will present the summary of this case, as this case has got long history to present and radiology discussion and future directions of the case with vascular. If time permits, we'll discuss a little about vascular slings also. So, Miss A, 5-year-old girl child, presented to us initially with severe wheezing episode associated with stridor and desaturation. So she was the first child of non-consanguineous marriage, term child, birth weight was 2.6, cried soon after birth, no NICU stay after birth. Her development was normal for age, immunized up to age, and her growth was height and weight between 3rd and 15th centile. Coming to the past history, so she had significant past history. So initially started with recurrent episodes of noisy breathing and breathing difficulty, requiring nebulizations, oxygen, HFNC support, which mandates PICU stay also many times, starting from 2.5 month of life. Otherwise, she was normal. There was no NICU stay till 2.5 month. She was normal, gaining weight, feeding well. And from 2.5 month of life, she started to have recurrent episodes like this. Most of the episodes will start with fever and rhinitis, which will progress to noisy breathing and shortness of breath acutely. Some episodes were documented as pneumonia episodes, wherein right lung is predominantly involved. So we could get a old CT chest from 6 months of life, but that didn't throw much light into our kids' presentation. The aortic arch was, it was mentioned that the aortic arch was left-sided, which shows a aberrant retroesophageal course of right subclavian artery. Right pulmonary artery is absent. Dilated bronchial collaterals are noted. Right systemic branches of aorta are seen supplying the right lower lobe. So essentially, there is a aortic arch which is left-sided. Aberrant retroesophageal course of right subclavian artery is present. Right pulmonary artery is absent, and right systemic branches from aorta are seen supplying right lower lobe. And there is a right lung collapse with a right upper lobe partial collapse. And intermediate bronchus is not seen and shows a small stem. So this is a complicated CT actually. So further, she had multiple episodes and she was managed from outside. All these recurrent episodes were managed. Sometimes she will be ending up in PICU with HFNC support, oxygen support. Sometimes she will be having a little less normal episode. Sometimes it will be pneumonia. So this was going on in her life. And at 2.5 years, since she had multiple episodes, each time it was associated with stridor and noisy breathing also. So each time this was associated with all these things, she was extensively evaluated at 2.5 years. So repeat X-ray at that time even showed a persistent right upper lobe collapse with hyperinflated right lower lobe. So coming then at that time, her bronchoscopy had done, which has showed right upper lobe secretions. We can see this bronchoscopy video. So we are going in vocal cord, trachea. Initially trachea appears normal T-shape. Going in, we can see we are almost at the carina. We can see right side, there is an opening and secretions are pouring from inside. I think the video is visible. Yeah, now we can see. Right side, the secretions are pouring out. And further, there is one more, further they couldn't go through the right mainstem bronchi or left bronchus. So right mainstem bronchus was narrow, left mainstem bronchus was also narrow. So scopes could not be passed beyond the right and left mainstem bronchus. And we could see a right upper lobe with secretions pouring out.
Just to interrupt you here, Just to interrupt
Yes,
you
ma'am.
here, the stridor was what, biphasic or expiratory? How was the stridor?
It was predominantly expiratory, ma'am. But
Predominant. So
inspiratory
therefore,
was also there.
yeah. So basically, you're looking at for an obstruction at a lower down level. Okay. The other thing
Yes,
what I
ma'am.
wanted to ask you, you did mention that there was a right upper lobe partial collapse. I could not see your bronchoscopy video properly. There was no pig bronchus, right? Right main stem opening.
Yes, ma'am. That is
Sumaya,
the point, ma'am.
Sumaya,
Yes.
can you be clear that
Yes.
this bronchoscopy was done not by us? So we managed to get the videos. So we just saw
Yes.
this child about a year and a half
Mm.
ago.
Okay.
So I think we have a limited information, but from what the videos we got, I think initially it was thought to be a bronchoscopy or a pig bronchus, wasn't it? And that was the
Yes.
kind of information which we had. I think this was in Delhi, I think.
Yes, sir.
So I think all this investigation still about a year ago, a year and a half ago, were at Delhi and other places too. They've been to multiple places actually. So it's a very interesting case. Okay.
Yeah. Yeah. Sure. Thank you for that update.
Yes, ma'am. Basically, yeah, ma'am. Basically, all this bronchoscopy, the CT angiogram, which I'm going to show next also, that was also done at 2.5 years, ma'am. For us, actually, child presented at 5 years of age, ma'am. Her past history is actually very significant. We are going through her past history, ma'am. So, coming to her CT angiogram, so further after this bronchoscopy, a CT angiogram was taken to make the picture more clear. So, Hiren sir, should we discuss CT angio now, sir?
Yeah, we can discuss. Shall I share the screen?
Yes, sir.
Yes, please. Sure.
So I'll go through the imaging aspect. So this CD angio was done which date?
It is in 2019, sir.
2019. Acha. So because we got the CT angio of 2021 and then one more at 24, I think.
Yes,
No,
sir.
Hiren,
Then
I think the first
it
one
will
was
be 21.
2018.
Pardon?
21, yeah, 21.
Yeah, 21 and other was so 24. Yeah, these two are there.
Oh,
Anyway, we'll start first with the X-ray just for the understanding of all the uh, delegates and those who are present today, how to go about the radiograph and what were the radiographic findings. So here we have been provided a frontal radiograph, which is covering chest, abdomen, both. And what we can see here that there is an homogeneous triangular shape opacity in the right upper and mid zone, and it is limited by the fissure which is horizontal fissure which is slightly upward. So that indicates there is some amount of collapse in the right upper and mid zone. The rest of the right lung, the lower zones and the mid zone, they are showing, if you see that there is asymmetrical hyperlucency in the right side lung field. So that indicates that there is hyperinflation of the right, this mid and lower zone areas. So when you see this kind of asymmetrical hyperinflation, you should rule out is there any proximal obstruction which is causing asymmetrical hyperinflation. That should be the first thought. It can be a mucus plug or foreign body, or it can be intraluminal or extraluminal obstruction that can cause this kind of asymmetrical hyperinflation. Then, if you look at the airway, and so this is the trachea that we can see. As we go lower down, the thoracic trachea should be it should be either same caliber of what we can see in the upper thoracic trachea till the carina. But here you can see that just near the carina and proximal to it, it looks like very small in caliber. We are not able to see the normal caliber of the trachea just above the carina. This looks like the carina, and even the left main bronchus also appears very small in caliber. So that is the X-ray finding. On the left side, we are not able to see any areas of abnormality, no consolidation, no areas of any other signs of infection. You can see that even the diaphragm also, right dome of diaphragm is more asymmetrically flattened as compared to the left side. So here the findings are predominantly on the right side. The right upper zone and mid zone showing areas of possible right upper lobe collapse, and rest of the right lung showing features of hyperinflation. And this finding, we have been provided multiple radiographs. So this was done on 10th of the May. Then after we had got many radiographs. One more thing to notice that I wanted to show that here that I can see some sort of coiling material in the mediastinum. So maybe the procedure was done. After that, we are seeing the radiograph.
Yeah.
So now I'll be showing you the
Hiren, Hiren, just on this X-ray,
yeah.
many a times a right upper lobe collapse presenting so early in life is a pig bronchus, and when you have one anomaly, pig bronchus is very commonly associated with any of these anomalies. Can you, on this X-ray, rule out that there is no pig bronchus because you can track the trachea down? So would you say that the right upper lobe mainstem bronchus we can't actually decipher from here, right? And the origin
Yeah,
you cannot
actually, yeah,
comment.
I'm not obviously seeing anything directly coming from the trachea here. But
Yeah,
see, X-ray is not that much specific enough or sensitive
sure.
enough to pick up the big bronchus. So we should not 100% rely on X-ray that possibility of big bronchus is there or not.
Sure.
I think just one thing that you can see on the X-rays that the distal trachea you cannot see well. You can see the upper and mid part, and then the distal trachea is not well seen. And you can see the left main stem bronchus is just very thin in caliber. And I think on one of the previous X-rays, you could also see a very thin right bronchus, which now in hindsight obviously is the lower lobe bronchus. But yeah, that's about it. No big bronchus and no, even the right main stem bronchus you can't really see well.
Yeah, yeah.
But that narrowing of the trachea near the carinal part and just just above the carina is, I think, something that can be noticed and picked up on this X-ray.
That I already mentioned that that was a finding which
Yeah.
create the impression that there is something wrong on the right side. Yeah. Uh, so I'll be showing now the 2021 city images. Yeah. So from the clinician side, is there any procedure was done like when the CT was done? Because I can see the coiling kind of material already in that CT scan, in the which was applying the right lower lobe. Dr. Sumaya, do you
So
want to comment
actually,
about this?
2021, the procedure might have done, sir.
Yeah, so I'll just open the scan in all three planes so that we can correlate better what we are dealing with. So first, I'll be showing you on the mediastinal window, right? So this is a mediastinal window, and on mediastinal window, we usually focuses on the vascular structures and the mediastinum and the chest wall. So I'll be starting from the top. So yeah, so this is the superior. Now I'll be starting the superior part of the mediastinum. As we can see here that behind the trachea and esophagus there should not be any normal vessel that causes. But here we can see that from the arch, this is the aortic arch which is left-sided, and from that we can see there is a aberrant right subclavian artery which is coursing and passing behind the trachea and esophagus. So that has been mentioned, I think, in previous CT scan which was done in 6 months of age also, right? In addition, what we are seeing here that there were some collateral which are arising from the subclavian artery. Here you can see that this is the large collateral which was arising from the subclavian artery, and that was going into the this kind of right-sided upper lobe region. And as we can lower down, now we'll be seeing that there was some questionable doubt of right pulmonary artery being absent. But as we notice here that so as we go lower down, this is the main pulmonary artery, and that is the RVOT and pulmonary valve area. So the main pulmonary artery, it is dividing into two. So this is the left pulmonary artery. The another thing that what we noticed here that usually the pulmonary artery, it goes either superior or anterior to the left main bronchus. So that is not happening here. Here it is crossing behind the left main bronchus. So it is locked, which is not normal. So this is the what we call as left pulmonary artery sling. So that is anomalous vessel which is coursing behind the left main bronchus, and by this anomalous course, it can compress the airway which is near the carina. So that is one thing we observed. Now talking about the pulmonary artery on the right side, we could see that there were some few branches which was supplying the right upper lobe as well as the right lower lobe. Here you can see that here is the branch which is coming from the pulmonary artery here. So it's not totally absence of the right pulmonary artery from the main pulmonary artery. It's the right pulmonary artery branches are small in caliber from the origin and within the lung. So that is another thing that we observed, that there was no absent pulmonary arteries in the right lung. So these are the findings that we can appreciate on the mediastinal window. Now, I'll be going you through the lung finding, which are lung and the airway finding, which are very important. Just wanted to highlight that whenever we have got some sort of metallic coil, that will show you this kind of hyperdent metallic artifacts. And it looks like some vessels were coming from the descending aorta. We can see here that that has been coiled in past. After that, the CT scan has been done. Now I'll be going you through the lung window, which has got many findings. Yeah. Again, I'll start from the top. Now we'll first focus towards the airway. Airway, I think you will feel and you will understand much better in the coronal view. So I'll just show you the coronal view. Uh, yeah. So here we can see that this is the cervical part of the trachea, which is looking normal in caliber. This is the upper thoracic part of the trachea. Now we can see here, this is somewhere at the T4 level. So generally we see that carinal division at T4 level as a standard anatomical landmark. Here what's happening that we are seeing some sort of the carina, which is showing some sort of trifurcation. So one of the bronchus, which is also very small in caliber, which goes towards the left side. That is one thing. Then this is the one more bronchus which is going towards the right side, and that supplies the right upper lobe area that we can see here. And there is one another small nubbin of bronchial tissue is seen in between this right and left bronchus. That can be some sort of rudimentary bronchus that was supposed to supply the right middle lobe, and we are not able to appreciate the right middle lobe in the present scan, and that might be just a rudimentary bronchus of the right middle lobe. That is one of the possibility. Now, if you carefully see the left main bronchus here, the left main bronchus also it is very slender and small in caliber, and you can see that there is one another additional bronchus which is coming from the distal left main bronchus that is supplying the right lower lobe. So that is also anomalous origin of the right lower lobe bronchus which is coming from the left main bronchus, and as we have noticed earlier that the pulmonary artery sling was seen on the left side, which was coursing behind the left main bronchus. So when it was crossing behind the left main bronchus, it was also causing compression of the right lower lobe bronchus that we can see here. That is very evident here. And that is the cause of this persistent hyperinflation that we have seen in all the radiograph that has been provided to us. It is behaving like some sort of ball valve mechanism and a compression on the right lower lobe main bronchus. The clue is that in this kind of complex case of airway malformation, if you go with the standard landmarks, like for example, that normal true carina, it will divide at T4 level, and this is behaving like a pseudo carina because you can see that right and left are dividing again here also. So this is a pseudo carina, and it is somewhere seen at lower level, somewhere T7 or that level. So that is not a level of true carina. So that we can label it as a pseudocarina, which is giving rise to the right lower lobe bronchus. Now, as we can see here, that the part of the lung in the right lower lobe shows some areas of crown glass opacity and partial collapse, and it is also showing some tortuous vessels which has been coiled. So I assume that there was some sort of systemic collateral which was supplying this part of the lung. Since the native pulmonary arteries are small in caliber, that can be a compensatory mechanism. We also could notice that this is the subclavian artery. From the subclavian artery also we were able to see tortuous vessels which were supplying, which were going extending inside the right lung, and in the right lung also we can see areas of ground glass opacity and abnormal tortuous vessels, some tuft of the vessels, and few dilated pulmonary veins. For example, this is the right upper lobe pulmonary veins, which is ultimately draining into the right in the left atrium where it should normally drain. So this abnormal tuft of the vessels and the dilated tortuous vessels and dilated veins, that gives suspicion that in the upper lobe there might be possibility of pulmonary AVM or AVF kind of phenomena happening in this position. So, and if you see carefully on the coronal view, you can see that the right lung overall, even though despite the right lower lobe being hyperinflated, the overall volume appears to be lesser as compared to the left side as you scroll from anterior to posterior aspect. So it looks like a complex malformation which is involving the airway, which is involving the lung parenchyma, which is involving the vascular structures. So like the bronchus which is coming from the left main bronchus, this bronchus is called as like in a terminology it is called as bridging bronchus. And this bridging bronchus can have various anomalies which can involve the cardiovascular system as well as lung parenchyma. The affected lung can be hypoplastic. Sometimes you will see absence of one lobe. You can see many anomaly in the airways, and you can see that pulmonary artery sling, left pulmonary artery sling that we have seen here. So that is the interpretation from our side, that we are thinking that this looks like some sort of complex malformation. Uh, yeah,
These
that
are
was the
these
thing.
One
are
quick
like
question.
please
Yeah,
go ahead. Please go ahead.
yeah. So
Sir,
that was the thing.
that
Go ahead.
left right upper lobes collapse, can we call it a sequestration, sir? Any vessels draining into that, sir?
Uh, You want to, Acha, you are saying that that could be a sequestration. Usually, the sequestration is not commonly seen in the right upper lobe area. Usually, seen sequestration in the area which is near the diaphragm. Then we are seeing this kind of abnormally dilated vessels. In sequestration, we don't see that like the affected part of the lung, which is small in diameter, and you are seeing dilated vessels within that area. That is not commonly seen. They can have systemic arterial supply, but they will not have this kind of abnormal tufting of the vessels within it. And if you see that carefully, so the pulmonary veins are draining normally in the left atrium. So it doesn't look like typical sequestration that what we see here. I would be rather worried about that.
Okay.
Are we dealing with some sort of systemic arterial AVM or like arterial AVF within the lung parenchyma, which has supply from the subclavian artery and early venous drainage into the left atrium.
Yes, sir.
So
One more
can I add
question,
some?
Dr.
Yeah.
Hiren.
Yeah,
The lower thing, the lower MAPCAs which have been coiled,
yeah.
were that the only supply to the lung? And if that was the case, is it right to put a coil into it? Because if that is the only which is giving blood supply to the lung, how can we, or can you see another systemic supply to the lower lobe of the lung?
Yeah, 1 minute. Yeah.
So
I
we
just
do
want to.
have cath videos also, right, sir?
Yeah. I just wanted to show that. So this is the native right pulmonary artery. You can see my arrow is pointing towards it. So right pulmonary artery branches were going to that right lower lobe lung area. Uh, so and to be definitive that the part of the lung which is medially here in the right lower lobe, that part has branches from coming from the right pulmonary artery. The definitive answer should be from the cath angio images. But I can see on this also that few of the branches were coming from the native pulmonary artery. Uh, so it was not only that the supply was coming from the systemic artery. Minimal supply might be coming from the native pulmonary artery as well. And they have done some cath angio images also. Shall I show that also? 1 minute.
Can I just add something?
Yeah.
So, Dr. Sumaya, your question about that upper lobe being sequestration. So, in sequestered lung, they only get supply exclusively from the systemic artery, right? Which is usually the aorta. But here, even in the upper
Yes, ma'am.
lobe, you are seeing few branches coming from the pulmonary artery, as Hiren showed
Okay.
before. So that rules out the sequestration. And why it is looking so dense compared to the rest of the lung, basically, it is a problem of ventilation perfusion mismatch, right? So your bronchus is very small and rudimentary, the upper lobe bronchus. So the ventilation is less, but your perfusion is a lot because you have branches both from the pulmonary artery and the systemic artery, like the subclavian artery collaterals, which are supplying that lung. So there is much more perfusion and less ventilation, which is why there's ground glassing in the entire lung, which you saw right from like the day one X-ray. That lobe had ground glass and kind of collapsed. So that is not a sequestration. That is because of the underlying ventilation perfusion mismatch.
Okay, ma'am. Thank you.
Yeah, Hiren, you can show the. Actually, in
Yeah,
this case, there is a pulmonary artery which is supplying both the upper lobe and the lower lobe, but it is small in caliber. That is why probably there was additional MAPCA supply to the lower lobe from the aorta, which they shut off, which is correct because then even the lower lobe will fail because of increased blood supply.
yeah. So just wanted to show the angiogram. So here they have done angiogram from that right side brachiocephalic trunk, and here we can see that this is the subclavian artery, and from subclavian artery you can see that this is the early phase which shows that tortuous vessels, and then yeah, you can see this kind of abnormal duct of the vessel within that upper lobe, and you can see now that there is early venous drainage here, and which is going down and going towards the left atrium. So that is behaving like a systemic AVM in this region.
So that a part of the lung, the upper lobe, is more
Mm.
looking dense just because of the vascular supply. And there's no bronchiectasis. If it would have been a chronic collapse, you should have expected some bronchiectasis coming in.
Yes.
All that is not seen. So it's just because of extra blood flow there, is it? Is that what we understand?
I think,
Extra, extra blood flow, and maybe that part had repeated infection also, because this part, because of the abnormal shunting and because the bronchus being small, it is prone for recurrent infection. So that is also
But
It,
one
there
of the
is
cause
no
that
bronchiectasis after so many
no.
recurrent infections. So that's
So,
why I was just wondering
so,
whether.
so, so that was the challenge. That's one of the challenges we have in this child, really. So, what is the right upper lobe doing is the question, because this child has had recurrent infections, but there's so many foci for recurrent infections in this child: the right upper lobe, the right lower lobe, narrow airways. So, I think one of the big challenges we have is what do we do with that right upper lobe? Thankfully, there's no bronchiectasis now, but what we have seen is a very aggressive management of the right upper lobe query infection. There has been a bit of a change on the X-ray with the density of the right upper lobe. So I think there's definitely a component of infection along with the other issues we have with vascularity and things like that. So that is one of the challenges which I think we'll discuss down the line.
Mhm. If I'm not mistaken, this is the native right pulmonary artery angiogram.
yeah.
Oops. Sorry. I think I need to reload again 1 minute. I need to reload the data. Sorry. So anything has been done for that right upper lobe systemic arterial AVM till now?
no, sir. Just this was 2 days. This was the CT angiogram done 2 days after the coil embolization, sir. In coil
Mhm.
embolization, they had mentioned that I will come to that, sir. I have a slide on that. But from iotogram, in the iotogram, they could see two collaterals, and they have coiled one collateral which is supplying the mid zone area. That collateral actually is draining into the pulmonary vein and into the left atrium normally, sir. But they have coiled that one since that was causing some sequestration. And another collateral, they had left it like that, sir. And nothing had been done to the right upper lobe part, sir.
Okay. But
But
if you see that
Hiren, in
right
the
up,
follow-up CT angio, you remember the subclavian collaterals seem to be occluded.
yeah, something they have done.
They have done
So
something.
this is the right lower lobe pulmonary arterial angiogram, in which we can see that medially there is no uh, branches which are supplying in the middle part of the lung. So I'm
Hiren,
not
we
sure.
Hiren, we
can't
can't see.
we
We
can't
We
can't
see
see
can't
it.
any
see
So you
this.
can't
images.
see.
Yeah.
Okay, 1 minute, 1 minute. Nice. Can you see now?
Yes,
Yeah,
sir.
now we can see.
Yeah, so this is the right lower lobe pulmonary arterial angiogram, in which you can see that all the branches are seen more towards the lateral part of the hemithorax. I don't see that medial part of the hemithorax, uh, that lung which was coiled. Huh? So, Dr. Sumay, you have to tell the angiogram finding, because they might have seen and done some additional cuts. So, what was their interpretation of the before coiling? Any idea?
Yeah, sir. I will. Can I show that slide, please?
Yeah. I'll just stop share for a while. Yeah.
So this is the documentation we had got on cardiac catheterization. They have done cardiac catheterization from plus coil embolization of feeding vessels of right middle zone. So there was in the previous echo, there was a PDA. So they had planned closure to be done on that PDA also. It was 1.6 millimeter initially. So they have documented tiny PDA 1 millimeter with insignificant pulmonary artery filling. So closure was not done. Pulmonary angiogram, they could visualize normal left pulmonary angiogram representing all segment as usual. But as we said, right pulmonary artery is small, only supplying the right lower lobe with no filling in the upper lobe. And from the iotogram, they had seen two big collaterals from arch and descending aorta. So it has been documented like one supplying right middle zone bronchopulmonary sequestration draining to right mid pulmonary vein to left atrium. That was coil, sir. This was the documentation we got on cardiac catheterization.
Okay. But what about why they have like coiled the right lower lobe area that they have not mentioned? Then mid zone appear they are telling as a this thing
They were
that right
saying
lower
it's a
lobe medial aspect.
sequestration,
Yes, sir.
which was
That
draining the
is
right. Yeah.
Basically,
okay.
they
Okay.
are mentioning it as a sequestration.
Yeah. Understood. But what I feel here that the major problem is in the airway and that left pulmonary sling which is causing trouble. That's why the child is having recurrent wheezing and recurrent infection. The main crux of the abnormality is there. So we have to deal with that first, then rather than going to target the lung, what is happening. Because these are the primary causative factors which is leading to all the problem. Now regarding right upper lobe, what to do? I think that has to be a clinician decision. If that is not functioning on and that is not contributing in anything, then you can think of doing lobectomy. Also considering a lot of abdomen top of the vessels are lying there, which has a propensity to rupture sometimes and cause hemoptysis and which has propensity to cause recurrent infection also. So if that is not useful, then you can think of doing lobectomy later. But first of all, we have to address the what to do with the major central airway anomaly and the left pulmonary artery sling. That should be a focus.
Yeah, I think I would agree.
One more doubt, sir.
Yeah.
That artery, you told subclavian artery forming a tuft of vessels in the
Yeah.
right upper lobe, right, sir? So
Mhm.
we didn't get any documentation of coiling of that lobe, sir, actually. So
Yeah.
such a procedure had been done in the, we could see that in repeat CT angiogram, sir. Ma'am was mentioning something like that.
Yeah. So we can see on repeat radiography in right lower lobe area, they have done that coiling material, but we are not seeing the coiling material from the collaterals coming from the subclavian artery. But in the repeat CT, if we are not mistaken, we could not see the continuity of that collateral from the subclavian artery. So we were questioning that whether they have done some sort of ligation or something. But you are saying that there is no procedure done, na, for the right upper lobe?
With the documentation, it is not there, sir.
Acha.
I don't think they've done anything to the right upper lobe, at least from what we can.
Okay. Okay.
But how
Is it
come, as in when they did this cardiac cath, they saw that there was like an AV malformation even in the upper lobe. So how come that was not addressed? Or we don't have an answer to that question?
We don't have an answer to
We
that
don't
question.
have an answer.
Because I think,
Okay.
look, I think by the time they did the whatever they did, the child had multiple issues, isn't it? So I think, as Dr. Hitesh said, it's a question of what do we do with all of these things. I think at that point it was felt that probably that sequestration question mark was causing the problems, but there are multiple issues, at least three, if not four issues in this kid. So the child was quite young at that point in time. It was not clear what was happening, and I think at the point of catheterization, they probably felt that's the right thing to do. So I think maybe that was we don't know. Now we're dealing with the kind of the aftermath of that and multiple other issues which need to be addressed.
Yeah, there's a question in the chat box. Can you stent the right upper lobe bronchus? I think the problem is also because of the collaterals which are there, and that is causing a bigger problem. I think stenting is not going to solve that problem at all. And when you have collaterals which are coming in like this, uh, uh, system that will cause more infection, that can has a risk of hemorrhage. So those are the bigger problems, and it's a malfunctioning lung. So stenting it may not really help. This is what I think. Dr. Naveen, would you like to add?
Yeah, I think I'd agree with you, Indu. I think it's a question of. I think we probably need to remove that lung, that lobe.
Hmm.
Yeah, at some point
Yeah.
of time that will have to be done, because even the risk of hemorrhage will be huge there. The
Yes.
infection, of course. Yeah.
But that will not solve your wheezing and noisy breathing, and
No, it
because
won't.
that is because of this uh,
It it it
bronchial anomaly. Yeah.
there are three or four problems here actually, so we need to pick and choose what to go with first. So I think the most difficult thing to address in this child is the airway. uh,
Yeah.
I think doing a right upper lobectomy may not be that challenging, but I think the airway is something which we need to really have a thought process about, because that is causing a few problems. So I think we'll discuss down the line. I think there are three, four issues to think about. So, but where do we go first? I think this has kind of been our big challenge with this, and hopefully we'll have some discussion around this.
Like, have you consulted the opinion from the cardiothoracic surgeon for the what to do for the pulmonary sling?
Yeah,
What they have said,
Yes, sir.
anything?
We are discussing that, sir.
I think see the pulmonary sling can be addressed. That is not the problem. But I think the question is, it's just not the sling which is causing the problem, isn't it? It's the
Yeah,
right
yeah, it's multiple. Yeah,
multiple.
even you might have to think of reconstructing the airway also. Is
So I think
over
the
the neck.
discussion we've had this far, I think the thought process so far has been, correct me if we're not thinking right. So I think the four things which we thought was: one, the right upper lobectomy. One, if it's causing problems. First, we thought we'll do a VQ scan and see where we are going. Second thing we thought we will do, because that's the easiest thing to do at this stage. Second thing we thought we should do is look at the right lower lobe, because that is a hyperinflated lobe, which is probably because of the compression of the airway, which may
Yeah.
get better with time. So that we can probably park for now. Third is the sling, which I think may improve that right lower lobe aeration a little bit. Now, the fourth and the most important thing is the airway reconstruction. So you've got this extremely complex airway and really not much space. So the last bronchoscopy, they talked about a few millimeters really. The child is a sitting time bomb actually. So these are the kind of thought process we had. But the question is where to go and when. And in the midst of all this, mom has just had a second baby just now. So the family wanted some time, and the child is quite stable with some infection management and very simple things that we've done, nothing complex. So the child has been quite stable and much better than before. I think we're just buying some time. So the point of discussing this case here is it's a very complex kid, and see actually, I mean, looking for ideas actually from multiple people. Our surgeons have had some idea, I mean, experience with airway reconstruction, but our CT surgeons, I don't think it's the right place for airway reconstruction. We're working on it. There's supposed to be another person who they want to get from abroad, where they can kind of come and do the surgery, which I think is a big issue now, the airway reconstruction. But again, we probably need to explore other centers who are capable of actually doing this kind of a airway reconstruction, because it's going to be very tricky. And any issue, because we don't have an airway pretty much. If anything goes wrong, it's a lower airway, isn't it? We can't do anything pretty much. The child will have to manage even the left lung may be compromised, because even the supply to that is quite a narrow airway. So it's a very very tricky one. The child needs to go on bypass, and we need to have a very confident surgeon who can do whatever he wants to do. So that's where we are at this stage. So ideas are welcome.
So, Dr. Naveen, actually, we have a good airway team. Unfortunately, they could not join us today. In fact, looking at your case, I wanted to have them over. Maybe we'll share this case with them and
Please,
get you some ideas if anything can be done.
please do, absolutely, because from a airway perspective, I think we need more ideas, and I think more hands on deck.
Yeah.
So,
So,
you don't think that just correcting that pulmonary sling will help improve, because at least that extrinsic compression for the time being will be removed and help with her aeration?
It might, it
Yeah,
might.
ma'am.
I think, see, as a stepwise, I think the easiest thing to do at this stage is your right upper lobectomy. Second thing to do
Correct.
your sling repair, which surgeons are very confident of doing. So I think
Correct.
discussions we had was at the time of doing these two, we'll look at the airway from inside and then see actually what it's looking like and go for a second stage or third stage or whatever. So these are the kind of
Correct.
we had. I don't think this child will manage with a one stage surgery. It's going to be a multi level with lots of people involved. So I think our plan initially at where we left it, at least with the family, was we'll go for a right upper lobectomy. First, a VQ scan just to look at what the functioning of the lobes. Then do a right upper lobectomy at the same time. That's with the surgeons involved. Then the sling at the same sitting and with the cardiothoracic surgeons. So do these two first, close the chest, and then see what happens. But I think we need to be prepared for, let's say something happens. This child is at a risk of bleeding. This child has got a very narrow airway. How are you going to ventilate this child when you're doing it? So child needs to be on a bypass and all that. So I think even these two simple surgeries carry a high risk because of the other issues we have with this kid. So a lot of thought process needs to go into it, and a very confident team needs to do it.
But I think I would completely agree with you. Doing these two procedures first, the lobectomy as well as the addressing the sling, and if one can sail past that, one can wait and see how the child is doing and then take a call later on for the airway reconstruction.
Correct. That was the initial thought.
Yeah.
I have one hypothetical question that if that right upper lobe is functioning and that is contributing for the overall status of the child, like by roaming, because your right lower lobe is look like more of a ball valve kind of mechanism.
Yeah.
So, like, is it like, are we going to more hamper the condition of the child by removing the upper lobe?
It may
VQ.
true. It may be true. And I think when we open up the chest, also, probably you can sometimes see, I think the surgeons can look at the state of the lung, also, isn't it? A VQ scan will only tell you about ventilation perfusion. So at that stage, that I don't think that thing is doing much, but it's a sitting time bomb because it could be infected, they could be bleeding, they could be, we don't know. It's hard to predict the future. So we could potentially go for the sling surgery, give it some time, and see what happens. So, but I think we just need to define what's happening with that right upper lobe. It's not very clear at this stage because from what we've seen, we've been following up this child for the last year and a half. It's not caused any major problems, at least with some infection control and things like that. It's definitely got infected at some stage when we first saw the child, but I think it's under control. But how long and suddenly there could be decompensation, we don't know. So these are the kind of we've discussed all of these individual issues also. So, but I take your point. Should we just leave it untouched for now? It may well be true.
Maybe yeah, we need to see the long-term prognosis of this condition, like bridging bronchus with multiple anomaly. How do these children do in their later life,
Yeah,
and how is the survival in those?
yeah.
Anybody has experience in this kind of cases?
Uh, I don't think so, really. Not at least from people we have talked to. Uh, I mean, the good thing about this child is she's got a good quality of life. She goes to school, she does other things. She gets wheezy, definitely. But she's not had any infections for the last year and a half. So that way she's been pretty good. But any mess up will just kill her. I think that's what it is. On
Yeah, yeah.
never
Is
want it.
she is she growing well? Is she putting on weight?
She has started actually to put on weight with some very simple things that we've done. So and I think she does all the right things. She's strong. She plays. She dances. Even with the V, she dances. She goes to school, and she's got a character. She's got a this thing. So anything you do should just have a little bit of a. I mean, see, sometimes we accept things that these kind of children may not really survive long term, like a CF. But I think at this stage, she's got a good quality of life. Whatever we do should enhance it and not shorten her life. So I think that's what we've been thinking and being very, very cautious with her. And hence this presentation today.
Sure.
Yeah, I think the
Uh,
best way forward is to get opinions from surgical teams and airway teams. And as you rightly said, that I don't think a single stage will work for her because there are too many issues that need to be fixed. And all of them, as you rightly said, again, are all sitting time bombs. So maybe just getting, proper opinions as to how this can be managed in a stepwise manner without causing too much damage, or as you rightly said, not shortening her life. I think that's the best way forward.
In the meantime, we will discuss with our airway team if they have any other suggestions and get back to you.
That'll be very helpful. That'll be
Yes.
helpful
Yeah.
because I think the more we chat with people, we'll have an idea. And I think we
Yeah.
just need a confidence of a team who can do complex airway work, really.
Yeah.
So,
Actually, we had one similar case, but the case child was not from Mumbai, and we lost the kid to follow up.
mm,
Dr. Hiren will remember we had that some
Yeah,
time
yeah,
back.
we
But
had. But that patient, I don't think that had this kind of query, sequencing query,
no,
AVM
he
kind of
only had
disturbance.
a bridging
Yeah, they
bronchus.
have only
The
breathing
child had
bronchus and
yeah,
pulmonary sling. So that
and
was
a pulmonary
relatively
sling.
easier to manage than
Yeah,
this child looks very complex, very complex.
yeah.
the advantage we have this family, it's a reasonably resourced family, and they're very good with what they do, and they're keen to explore anything we suggest. I think the trust is there, and I think it's important to kind of match up to that and do the right thing. So yes, that'll be helpful.
Mm.
All right.
Yeah, there is one
Any
more
other?
feedback that she is getting better and growing, then don't need to do anything right now. That
Right.
is also one way to look at this.
Masterly
Need
inactivity,
to do
as they call
anything.
it.
I think masterly inactivity with a very clear plan in place is what we'd been working on for now. But
Yeah,
it's good to have options in place, isn't it? If something happens, one, two, three, what do we do?
Correct.
yeah. That's a great case. And I just, as a radiologist, want to, I don't know if there are any more radiologists here, but I think we are at SRCC, we have a very active cardiothoracic surgery team. And just to highlight that this relationship between vascular anomalies and airway anomalies is a lot more common than we anticipate. Very often we see dilated pulmonary arteries compressing the bronchi uh, and things like that. Also a lot of inherent intracardiac abnormalities associated with airway abnormalities that really complicate the cardiac thoracic surgery work also and make it very hard to manage the patient's intra-op and post-op because of the coexistent airway anomaly. So I guess the take-home point is that if you see a vascular or an airway anomaly in a CT scan, look for the other and vice versa.
Yeah. The problem with kids is, in an adult, if you have an airway anomaly like this, with or without a vascular anomaly, they can stent, but in children, we neither get stents of this size, nor
Yeah.
is it like at this point of time, metallic stents we can't put in kids, the silicone stents we don't get the size, and there is no long-term data or maybe even experience with many centers of using the stents. So procuring them and the biodegradable stents were tried, and in some centers where they tried the biodegradable stents, the stents disappeared much faster than they were supposed to be there. So there are a lot of issues, stent migration, infection, and in a child with a growing lung where we want to do it at the earliest because we don't want to compromise the growing lung. So there are a lot of challenges, I guess. Yeah.
True, and I think this being a very long segment airway problem, and I think multiple level airways really, isn't it? It's the right, it's the left, and you got the sling. And sometimes, I mean, with long-standing slings also, you can repair the sling, but the airway can be quite malaysic. So even that is
Yes,
a bit of a toss-up.
Yeah, yes.
absolutely.
So I think multiple challenges. But I really appreciate the way you showed us the images. I think it gave us a lot of clarity as to what we're looking at. I think each time we see the images of this kid, we learn something new. And I think
Yeah,
we
yeah.
learned something really new today. I think, especially with your presentation. Thank you.
I just have
Thank
I
you.
just have one question clinically. If she has such a large pulmonary AV fistula or a systemic AV malformation in the upper lobe, uh, she hasn't manifested any signs of that in terms of hemoptysis, in terms of congestive heart failure or like a high output cardiac failure.
No,
That is the surprising thing also
true.
I
because
think
it's a very large one, what we saw at least on the angio, very large systemic vessels draining into the pulmonary veins.
Yeah, but I think none of those so far.
I guess it is a matter of time when she would do that because we had
Yeah,
presented a similar case with lot of AV malformations, and then that kid presented only with hemoptysis, and that was the main presentation. But it's like anybody's guess when such a child would you know kind of
yeah. So I think that is also something. So maybe Dr. Naveen, that you all can have like a surgical team ready, the day she goes into hemoptysis or something, she will need an emergency lobectomy,
True.
which was our learning from that case. We tried to coil that AVM multiple times, and eventually she needed a lobectomy because AVMs are notorious. They keep recruiting new vessels.
True. True.
So, have that surgical opinion and that surgery team ready if she ever needs something in emergency, then should have like something ready for her.
True. I think point taken. Yeah.
Yeah, that patient of ours, we had put 8 coils. Twice we took her up, and finally we had to do a lobectomy. And also, she also had ladded up with infections. So there were a lot of issues. So finally, the lobectomy had to be done.
I'll dread the day when this child has a hemoptysis because you're going for a lobectomy, right? Upper lobectomy, and we've got no airway to ventilate at all. You've got a 2 millimeter or 3 millimeter airway from a anesthetist point of view. That'll be something to think about.
Yeah, somebody's drawing that.
Drawing it over there. So Maya's drawing it
Very
over
good.
there. It's really cool.
Superb,
That's
superb.
exactly
This
what
is
is happening.
amazing.
And
Amazing.
one more doubt. One more doubt, sir, that we didn't comment any dysphagia, the esophageal compression, any dysphagia, vomiting, any of that was also seen,
No,
or
no, she's never had major. I think she's never had swallowing problems. Nothing.
Because of the aberrant subclavian and all of that,
because
right?
of the aberrant subclavian and the sling?
But that we often
Thank
see
you.
as an incidental finding. It may not be
Yeah,
causing
yeah. And
disease.
patients are,
We do see many cardiac disease with that aberrant supplement, but we have hardly seen any supplement artery which is
Sure.
aberrant that is causing obstructive symptom. That is
I
that's
think,
not much common.
Hiren, those children forget they're dealing with their cardiac and airway issues. They forget
That's
that they also
dysphagia,
have
very minor thing, I think.
dysphagia. That's like something I can deal with. I'm breathless all the time.
So essentially, this is the crux of the case, ma'am. So here we have a tracheal bronchus, which is draining into the right upper lobe collapse. So
I mean,
that has
no,
got some.
I would not agree with that tracheal bronchus. This is actually your true
Mm.
carina.
I think
This
yeah.
condition is called as bridging bronchus, in which the true carina will be giving rise to this right upper lobe and the
Yes.
right lower lobe bronchus. So right lower lobe bronchus is continuing lower down as a smaller cylindrical bronchus, and from there your right lower lobe bronchus is coming.
Yeah, I
So
think I would
your
agree.
true carina
Yeah,
is at
Yeah,
I
right
think
upper
yeah.
lobe is
I think it's anatomically a
Mm.
small right-sided bronchus. Uh,
Yes.
Yeah.
and what we are seeing less of the anatomy is your left main bronchus, which is produce a bridging bronchus and all that. So
Have you
Yeah.
bronch this child again after the first bronchoscopy done outside?
we haven't. We're planning to. I think mom's just I said mom's got into
Yeah.
delivery. I think and child is so
Sure,
stable. So
sure.
even a bronchoscopy, I mean, especially this
Yeah.
child would be
Again,
high risk.
ventilation issue.
Yeah. So we'll have to do it very carefully, but we'll do it. I
Yeah,
think that's a plan because just I think looking for the opportunity, the next one.
thank you so much.
Thank you for showing this
Fascinating.
difficult case. Yeah, it was very good.
Yeah, thank you. It was really a
Thank you.
wonderful
It was
case with
I
an
just wish
anomaly
that
at
we had,
every level.
yeah, yeah. I just
Yeah,
wish we had some sort of surgery or ENT people together in this case, so that it would have made it more interesting
yeah,
from their point of view. That how
yeah.
difficult will be the surgery and what will be the post-surgical care. And that would have made a few more points.
I think we'll have to put this child on pretty much bypass or ECMO to do anything really, isn't
Yeah,
it? So
absolutely.
and then protect their way. So very complex. I think I'll look forward to what your surgeons say, Dr. Indu,
Yes,
and
we will get back to you on that.
and
Uh,
and thank you very much for the really nice inputs and discussion.
Thank
Thank you
you.
so much. I love
Thank
the way
you.
Hiren and Sonal described why it is not a sequestration. That was a good learning for me too.
True.
Thank you, thank you. Thank you everyone for joining.
Thank you, everyone. Another very complex case and a lot to learn, and hopefully more guidance regarding the management of this. So, thank you, everyone, again for attending this another informative session of Pulmo Radio Crosstalk, and see you next month.
And Tanvi, I think we should thank Sumaya for digging up the
Sumaya done
data
excellent.
because we had to get the images and the videos from multiple sources. I think she's been working on it for the last 1 month or so because we've not done the
Absolutely.
test.
And hats
Wow,
off to
thank
her.
you,
She shared it
Sumaya.
to us. Yes, and she shared it with us also well in advance. So we also had time to sort of go over it and, form our opinions and discuss it. So Yes, thank you, Somaya. It was really nice that you could send them all on WeTransfer. They were crystal clear, and you kind of got your hands on everything that you could. So, yeah, thank you.
And the
Including
enthusiasm
the
of our
essays,
youngsters.
including
Keep it
essays,
going.
NGOs.
Yeah,
Yeah.
and Somaya, I think you have a side profession also. I think you're a good sketcher.
Yeah.
I mean, when if
You've
in
drawn it
future,
very well.
if you in future you're planning to write up this case report, you can exactly put this schematic diagram. That will
Yes,
be very useful to
excellent.
understand. Yeah.
Yes.
Welcome, ma'am. Welcome.
Yep. Yep.
Thank you all. Bye bye.
Thank you very much, Naveen sir. Thank you, Somaya, once again. Thank you, Hiren sir, Sonal ma'am, Indu ma'am, Sanjeev sir, for being here. Have a good day, everyone.
Thank
Bye.
you all. Bye.
Bye bye.